Welcome, everyone. I'm Dick Deming. I'm Medical Director of Mercy One Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And our topic tonight is care for the caregiver. And our guest is Kathy Koenig. Welcome, Kathy.
Thank you.
So Kathy has a master's in social work, and she's also a certified caregiver counselor and coach, and she provides caregiver counseling at the Mercy One Richard Deming Cancer Center.
Yes.
So it's an honor to have you here as a guest, and even more importantly, it's just great the care that you provide our patients and their families.
Oh, thank you. It's a joy for me.
So let's learn a little bit about you before we learn about care for the caregiver. Where were you born?
I'm Des Moines, born and bred.
Des Moines, Iowa. I know that place.
Yes.
Yeah.
Yes, I wandered as far away as Iowa State and Ames for college, and then got a master's degree at Drake and have had a series of careers living here.
So high school here in Des Moines.
High school here, yes.
And then Iowa State.
Mm-hmm.
So what was your first declared major when you went to Iowa State?
English.
Mm-hmm. And at what point did you switch from English to, did you switch to sociology or what?
Yeah, I probably switched after one quarter and just sort of in that freshman sort of winding my way around. But yeah, I found sociology to be interesting to me, sociology, psychology. And then at that point in time, they were building out a degree in sociology and social work. And that felt like a fit.
Okay. And then did you say you went on for a graduate degree at Drake?
Yes.
And what was your first job after you got your master's degree?
Well, I was working at Iowa Methodist while I was getting my degree at the same time. And so it was back in the day when they actually paid for a degree. So
Gotcha.
it was a great deal. And
so you were a medical social worker?
So I was a medical social worker and got my degree, but then towards the end of that, I pivoted and went into adolescent medicine, went into adolescent behavioral medicine for about 5 years. And so I did inpatient, outpatient, and day treatment, family therapy.
And that was outside of the school system. And
yes,
that was,
yes,
again, medical.
It was in the Methodist had a program once upon a time. So,
Gotcha.
Yeah.
And obviously, you're now doing work for us in the cancer center. And the role that you're playing for us is not so much counseling the patient with cancer, but family members with cancer. So we call that the caregiver.
Yeah.
So sort of the lay caregiver, as opposed to you're not there on a daily basis counseling me as a caregiver, but the family caregivers.
Right.
When did that become a focus of your work? And over the course of, being a medical social worker with the patient as the primary person, but you can never just treat the patient in a vacuum. Talk a little bit about the evolution of having the patient with the disease being your primary focus to having the caregiver of the patient be your primary focus.
I would say that I had the great fortune of not only working with patients with all kinds of different illnesses and disabilities, but mostly a lot of the people who had neurological issues and strokes, spinal cord injuries, and people were in the hospital for longer periods of time then. So I had an opportunity to really get to know families and sort of pay attention to their strengths, and we had time to work on the dynamics of what was happening, but what the longer arc of the situation was going to be in helping them prepare. And I don't know, I guess my heart has just always been around healthcare or medical related issues, so that even when I eventually left that, I went to work in a psychiatric practice for several years. But then I worked with people who had a special in migraine headaches. I worked with some neurologists around that, but liked also working with a lot of elderly people and people who were most of the people that I saw had some sort of health related type issue. So maybe it was just some sort of attraction that happened there. So I guess I just had a comfort level with things that were health related. And then I was also a family caregiver for my father, who had been widowed when I was a child. So towards the end of his life, I did a lot of caregiving for him. And then my husband and I did some pretty intensive short-term caregiving long distance for his sister who had a terminal illness. And it was really at that point in that situation where I thought, here it is, we're pretty skilled at this. And it was very hard working in other systems. And I thought, if it's this hard for us, I've got to find a way to make it easier for other families. And pivoted into, got certified to teach programs like Powerful Tools for Caregivers and some other things, and really kind of dove more into working more specifically with caregivers.
So I think historically, we treated the disease that the patient had and assumed that they would get the soft cuddlies and support somewhere along the line, and didn't think of that as a medical necessity. And then over time, really began to realize that caring for a patient with cancer is about a lot more than just killing cancer cells. And so the history of providing psychosocial support to the patient became an expected part of care. But the idea that we're going to expand that circle and actually provide professional help to the family members, because it's like, well, how are we going to bill for that? The family member's not our patient. I mean, I'm a little tongue in cheek, but not totally, because who are our constituents, and who do we serve, and who do we bill? And but fortunately now we are in a system where we're able to do that. And just, not that it matters, but the billing side, we just cover by philanthropy. So we don't have to ask, okay, you're going to see a married son of a patient in another state and talk to them on the phone. How do we have to register that person? And that's been able to be resolved through philanthropy, fortunately, and now have the ability to bring your caregiving services to caregivers that can be defined very loosely. It doesn't have to be the spouse. It doesn't have to be the child. Talk a little bit about, what does it mean to be a caregiver in the sense of like the oncology practice?
First off, I just want to thank you for the benefit that you offer to families, to caregivers. It is cutting edge, and it is something I've long dreamed of. And I think it does make a difference because they're an essential part of the system. There's even sort of becoming a shift in the caregiving world about talking about, do we say the word caregiver because sometimes that has a certain connotation, or sometimes the word care partner, because they are in a partnership, not only with whoever they might be providing care for, but also hopefully with the medical team. They're attending appointments. They become chemists overnight in terms of understanding medications, labs, all kinds of things that with no previous background.
Right. And even in
astounding.
The hospital, I can't imagine some patients, if they didn't have their lay, family member there with them in the hospital, especially during COVID. Oh my goodness, it was providing care and the face masks, and then people were afraid to go into the room, and then heaven forbid that the patient actually did have COVID, and the isolation they felt. And
right. Yeah, it's the advocacy that caregivers or care partners provide is essential, because the patient may have a certain sense of their own illness or answer questions in a certain way, sometimes hoping to be brief or liked by their by their medical team, or not want to be a problem, or not even perhaps have a sense maybe of how fully a situation is. And so sometimes having that other person there in the room to say, oh, yes, and there are these factors that then perhaps when you hear that, you think, oh, okay, I thought we were going down this path. Now I know I need to go this way.
Mhm.
Um,
Yes. The number of times where the patient just sugarcoats the symptoms and minimizes the symptoms. And you can see the spouse is just like rolling her eyes, going, well, here's what he's not telling you. He says he's doing fine. He hasn't eaten in 3 days. And
Yeah. And part of that, it does come up in conversations that I have with my clients, that they will say they're not saying what I know to be true, and I'm angry that they're not doing that, and they don't want me to say it either. And so it creates this like, well, that's not exactly helping the whole situation. How do we do that? And sometimes it depends on the situation, but I might advocate for caregiver to write things down that they observe, and when they're registering or whatever, just say, oh, could the nurse see like pass that in first, so that you all have that information going into it. So it might lead your questions in a particular way, or you might think, because sometimes people will say, well, they didn't ask me that,
mhm, yes.
and I want to know, but I sort of don't want to know. There's a lot of ambivalence, I think, that happens. I think particularly in cancer care, I think it's scarier than some other things. And
Yes, because the issue of mortality
yeah,
is in the room from day one. Even
yeah,
if it is a favorable cancer with a great prognosis, the fear of you have cancer and the fact that this could result in, premature death before you reach your ripe old age, and obviously. Patients that come in, and so let's say the typical situation is a married couple, but it's also very common that maybe the patient is widowed and it's grown children
Yep.
that are coming in, and then you often see where they're at that verge where the children are becoming the parents, and there's some resentment there and difficulty. And just because one person in the room has cancer doesn't mean everybody is going to be sweetness, happiness, and it's not going to resolve all the family issues
Oh.
that might have existed for decades. So that all can play out as well.
Right. And not everyone is wired to be a caregiver.
Mm,
And I think
mm,
that that's an important thing we don't spend enough time on. And sometimes we don't discover it until we're into it. And somebody's saying, when is this going to be over? I'm sick of this. I've got a life I want to get back to. And then trying to figure out a way to realign things. Who else can we get in there to do the things that you're not liking to do? What roles would you like to play? Some people are excellent at doing the research or managing all the EOBs, all the paperwork, and organizing that and fussing with the insurance company. And somebody else is really good with the personal care. And somebody else is good at just kind of coming and visiting. And so figuring out who can do what. And perhaps somebody lives at a distance, they can't be there, but maybe they have the financial wherewithal that they can contribute something on a monetary level, because there's a lot of ancillary
mhm.
expenses that a lot of caregivers end up assuming. And
That's a good point. As you went through all of the different roles that a caregiver plays, from just moral support and being by your side as a teammate, and we're going to go through this together, to some pretty significant providing of physical care, whether it is with bathroom issues
mhm,
or nausea, vomiting, diarrhea, or giving of medications, or wound management, or drainage tube management.
mhm,
Some of those things, in decades past would have been a medical professional doing it, but now it's get you out of the hospital, get you home, and figure out with your family how to do that. Or with home care, but even somebody who has great home care, it's maybe an hour a day, and
Right.
there's 23 hours of family care. So obviously the physical care, but then the advocacy work of investigating, and do we want to consider clinical trials and second opinions, and how do we get those appointments? How do we manage the insurance end of things? What about being off work and short-term disability and long-term disability and FMLA? And then the finances of how do you keep it all going? Many different roles that caregivers can play.
Right. There are some clients that I have through our service that I don't even see, that I, at least physically, that my relationship with them is maybe more by phone or via email. And I'm thinking in each of these cases, it's a woman at midlife who is needing to work because her husband has a diagnosis and is off work, and so she's carrying the family financially and carrying the insurance.
And his insurance might be from her job.
Exactly. And she's also trying to be at his other appointments. So coming to see me it does not need to be a stressor in their life. And so what I try to do is work around what's the best way that I can be helpful to you. So I will touch base with them just periodically, or I love just connecting people to, if a resource comes my way and I think, oh, this would be great for so-and-so, then I'll just, text them that or email and say, here's something that might be helpful.
As you're describing this, I can see, okay, this is the mind of a social worker. So she is not just a mental health counselor. You're first of all, social work. How do we figure out, how do you get the stuff done that needs to get done? There's this practical stuff that just needs to get done. But I would say that I thought of bringing you on, not even realizing that you could help with all that practical stuff. The reason I thought that we needed you is that in the act of doing all of this, the caregiver who doesn't have cancer often feels like they can't really ask for help because it's my spouse that has cancer that's maybe going to die, and I'm just not worthy to ask of time for myself. And because of the situation and the caregiver not being the one with cancer, thinking, gosh, I should just put myself in the back seat and just, be a martyr and give. But there are times where their needs just can't be met by the patient, and they feel even guilty of asking for some support. And that's where having a professional that can be their caregiver, their resource. Maybe talk a little bit about the sense of guilt that some caregivers have to even ask for help.
Yeah, I if there was one thing that I could cure on this planet, one thing among many, it'd be guilt, because it's this insidious and basically unnecessary emotion that we carry over for so many things. And in most of the cases, most of the stories that I hear from people, they are not doing anything but trying to be loving and accommodating until they are just drained dry. And I think it can sometimes come out of if the person they're caring for says, yes, but you were gone all morning, and they might have been gone for 1 hour doing something. It's like, like I can't. It's sort of that dynamic. You're right. Of like, they have this illness, and instead of it, I try to get them to look at it like this is a we. This is a we event, that it isn't just this person. This person might be carrying the illness physically, but this is happening to a system. And that you are having to carry, sometimes what ends up happening too, and people will say it, is that I feel like I'm living two people's lives. And trying to do a really good job with both of that. And so, yes, asking for help or thinking I can do this, because sometimes I think that's just our Western way. And asking for help is vulnerable. But sometimes sometimes people come in, and this was true in my therapy practice too. I've just realized that I don't need a lot of accoutrements. I need a box of puffs and a glass of water and a wastebasket and comfortable chairs, and we're good. And people just sometimes sit down and they will just start to cry, and then they will apologize for that. And I was like, no, 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 we're good. That this is just a release. It's a release of stress. It's a release of emotions. And this is a safe place to talk about whatever it is you need to say. I think that there's also the concept of gratitude is really tricky too. I should just be grateful for this, or I'm grateful for that. Gratitude's all good, but sometimes it's a little bit of a sticky trap because it sort of doesn't always allow the whole range of emotions. And very often somebody is really angry about stuff. I'm really happy to hear that. But very often I will find under anger, there's some fear. So if we can kind of just get down to it and explore it, then we can work on solutions. And
so pragmatically, the way it works, so I'll see a patient and recognize that this patient would certainly benefit from a counselor to talk about, let's say the patient has a cancer that is treatable but not curable. So the whole existential fear that this is going to progress, fear that I'm going to die, fear that I may not have everything. So yes, we've got certified counselors that are going to work with you to help ease your fear, anxiety, make sure that it doesn't become as big an issue as your cancer. But then I will also recognize that their partner, their life partner, let's say their spouse, is also dealing with many issues. And sometimes having the two of them together in a room with a counselor, they have different needs that need to be talked about separately. So then I'll say, and for you, we also have a caregiver counselor that I'll arrange for Kathy to meet with you. And my question is, because I don't then see that first encounter that the patient, let's say Joe, has with the caregiver, with the counselor. And I certainly don't see the interaction you have with, let's say, the spouse, Mary. Are there many times where you maybe don't meet Joe?
Oh, yes.
You just meet Mary.
Yeah.
And you learn about Joe's illness from me telling you what the situation is and sort of the treatment and the difficulties and the prognosis. But when you meet Mary, she is your client, and it is probably important that Joe's not there for that appointment. So there's many times where you'll meet the spouse or the adult child, but you never will meet the patient.
Yeah, sometimes. And there have been a rare time when I've seen people together, and that's always interesting because for as many people as in the room, there are that many realities. For the family member, for the caregiver, care partner, it's my opportunity, or the opportunity, to say, like, how are you doing? And sometimes they're a little taken aback. And I said, I'm sure that probably a lot of people that say, how are things going? How are you doing? But they're really meaning, how is Joe and his illness? And you're this just reporter. And they'll acknowledge, like, yeah, nobody really asks about me. And it's like, yeah, I want to know about you, and you can tell me the story of what's going on. And I'd really like hearing it from them and their perspective. But yeah, sometimes just for them to know, oh yeah, this is just for me. This is just for you.
What are some of the major themes of issues that are causing distress in the life of a caregiver? And again, we're talking about the care partner, the family member, the spouse, or the adult child.
It can come in with many different flavors, but there's the sense that one major storyline is, am I doing a good enough job? Am I doing the right things? I'm fearful of making a mistake. If I make a mistake, will it be the thing that tips it to a different, over the edge? What if I miss something? And so there's just this like almost perpetual scanning, I think that just can become exhausting, for like, how are things today and how did you eat? And, let me get this for you. And have you had your meds yet? And, I'm going to go to the store. What would you like? All right, I'm going to be gone. I'll just be gone this long. You text me if you're if you need anything. And it's just like, there's just almost like never some rest for the nervous system.
Hmm. Hmm. Always on a high
Yeah.
high state of alert.
Yeah. 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 And I think that there are the moments that are sort of sometimes when somebody is having treatment and it might be like 3 weeks on and then a week off, then everybody looks forward to that week off, like, oh, good, we might get to do something, or we might be able to exhale for a few
Mhm.
days and do something before we're into this routine again, or in between. It's like some people will come and they're like, well, we're in a period of, things are calm right now, and then just hoping that they stay calm and working towards getting sort of realigning their lives again.
So one of the issues that I see both for the patient and the care partner is this anticipatory grief. That what they're really feeling is this sense of loss that hasn't even happened yet, but that I'm not going to see my grandson graduate. I'm not going to be there for my granddaughter's wedding, or I'm not going to see grandchildren. That even if my physical symptoms are kind of under control, I just have this sense of mourning a death that hasn't happened, mourning and grieving for events that will never happen, and that can be both the patient and the family member, and it's difficult to even talk about those things with each other because they're each was trying to buoy the other in terms of getting through this.
Yeah, exactly. They are sort of like conversations that sort of are on different paths instead of on this. They're on parallel paths, but they're not intersecting enough. And I am somebody who does weave a lot of grief work into the caregiver work. I think that it's an intersection that has probably been ignored, and it made sense to me that we've for so long thought about grief just on 5 stages, and that takes us back to 1969. Unfortunately, we've come a long way since then, but that there's all different kinds of losses that are happening. And it might be just, the loss of income, which is huge, the loss of sleep, the loss of independence, the loss of socialization, the loss of being able to go to a job. But it's the loss of
intimacy.
Loss of intimacy, and that, that can be sexual, but it can just also be just the connection. Somehow the connection has gotten broken by this darn disease, and it's now gotten, it's taken over, and it's on, got all of our attention, and trying to claw back just moments of joy and where we can find that. But there's, and being able to talk about that and recognize it. And when I bring it up with my clients, no one ever says, like, I have no idea what you're talking about. They're like, oh, so that's what this is that I'm going through. You're naming it. You're naming part of what I'm experiencing. And probably some of the research shows us that in about 50% of cases, people will experience anticipatory grief, which is that sense of that there may be a death coming. And maybe we know that as part of something, and almost like it becomes a buffer, like we begin to anticipate or imagine what that will be like. We might be gathering information. Sometimes if people are using palliative and then hospice care, and those are 2 different services, but they can get more information about what to expect. And so it's like, okay, so when that happens, all right, I know what's going to happen, so I won't be as fearful, and I won't make mistakes, and all of that good stuff. But the anticipatory grief doesn't if there is a death, it becomes a whole new thing. And people will say, I thought I was ready for this, and this was a whole new animal.
Right. And then, we use the term anticipatory grief, meaning something that's going to happen. like the death of the patient, but there's also true grief for just the loss of going to the movies,
Yeah.
the loss of Sunday evening sitting on the couch eating popcorn without a care in the world. I mean, those joyful experiences are gone, and you really have to work to figure out how are we going to find some joy in the midst of this journey.
Right. And another form of grief you and I have talked about is ambiguous grief. And ambiguous grief can occur when, say, the person is there, they're living, but perhaps they have, some form of cancer that is really causing confusion for them. The individual's altered in a way that they are less the person that they were before.
Yeah.
And so it's like they're there, but it's not the same. A really good example would be more in like dementia, where somebody is, there, but not there. And, there's a lot of different forms. And the ambiguous grief can also come from some of the estrangement that shows up in family situations. As you said, just because people have this diagnosis, their family dynamics don't always improve, but it may mean that somebody is out there, and there could be a sibling or somebody that's like, we don't even know where they are, or we know that they're there, but we haven't been in touch for 15 years. What kind of connection are we making now? And it gets complicated.
Mm-hmm. So when you work with a care partner,
Mm-hmm.
Typically, how would you approach the first meeting, and then how often do you meet with care partners, and maybe share with us some of that work?
Okay. One of the ways I can draw it for somebody on a piece of paper very simply, or just in my head. I like the concept of circles, and sometimes I'll just like 3 concentric circles. So like there's an innermost circle, and generally the patient is going to be in that circle, the care partner, whatever, and maybe who's closest, who's really in our inner circle, and it might be members of the medical team. And then there's another slightly larger circle. It could be more family. It could be neighbors. It could be the person who's now going to walk the dog for you,
Mm-hmm.
on a regular basis, or take your trash cans in and out, or friends and family. Then there's generally an outer circle of people that you might pull in at a later time. It could be other ancillary health professionals. It could be friends. It could be other resources. But I like to assess how people feel supported, or who is supporting them. How isolated are they now? Are they doing this on their own? How often are they getting help, or do they even feel like they can ask for it? Because that's a whole other topic. And also just beginning to talk about who can you ask for help, and how would you do that, and the vulnerability of doing that, but also having the permission to do it. And so I would begin that way, and the conversations generally are very easy. I think people are so willing to talk. Most
Yeah, I'm
sessions,
sure an hour session just flies by.
I mostly schedule 90-minute sessions,
Mm-hmm.
because in the world of medicine, you're not getting that much time really anywhere else, and it's all about you. And there's so much for them to just unload, and for me to start sorting out that. Then I can start thinking about things that I can offer them on the spot, but then in the future. So some people I might see initially, maybe depending on how things are going, maybe for every other week. Then it starts to stretch out into maybe once a month or 6. In some cases, it might be just once that they will come.
Mm-hmm.
So it's really variable, but
What about adult children? So I'm thinking of referrals I've made where I'm in the room, and they are adult children that live here and are affected in a way. They may not be doing the heavy lifting they don't live in the same house. They're not that day-to-day caregiver in terms of the medications and the eating and the hygiene, but Typically, you would meet with each of them individually
Hmm.
rather than collectively.
I will do, particularly from the outset, I will do what they feel most comfortable with. I don't have like hard and fast rules about
Mhm.
that. It's like, what do you feel comfortable with? Because just even coming to see me is, maybe just scary enough. I try to make it really non-threatening because I am really non-threatening, I think. My goal is just to be helpful. But just like, yeah, who wants to come? Let's sit down and
Mhm.
talk.
Mhm.
And um, but and I've had a couple situations where it's been multiple family
Mhm.
members in the room. I had one situation, we built it around a family member who was living in eastern Iowa and wanted to really be there. So we
Mhm.
even built it around a day I'm not normally there,
Mhm.
so that person could, so many people could be
Right.
there.
And some of their issues might be, I'm the daughter. I'm the one who's always having to do this. And my brothers, yeah, maybe they throw in a few bucks here and there for gas, but it's just expected as the daughter. I'm the one that should be
Mhm.
taking off work and supporting our parent who's going through this difficulty.
Yeah, that's a fairly familiar
Yeah.
story. um, and yeah, I think there are some just maybe societal roles that have occurred over time, and that's where I like to figure out who's the best suited for a particular role too, because an eldest daughter may not be your best person, and having a resentful caregiver is not helpful for a patient. And even if somebody is even nonverbal, they can read the energy. You can read somebody's body language, the tone of voice, the look on the face, and no one wants to feel burdened. I think the other thing too is that sometimes it can be kind of tricky if there has been an issue with the parent before and it's not been a healthy child parent relationship. And so you have children who are willing to do it, but they're carrying a lot of stuff from the past. And so we try and settle as much of that down as we can, so that they can get through what needs to happen or figure out who can do the care, so that that's maybe the best that they can do. Maybe they're not going to be the ones to offer it, but we find a way to have somebody safe. I want situations to be safe for people and not just fragile and kind of cobbled together.
When you meet with the caregivers, I'm sure the conversation includes many different things. Is there any particular theme about how the patient is getting their professional care? Are there themes of not getting to spend enough time with the doctor, not really knowing what's going on, or what would you say are themes that the caregiver mentions about the professional care the patient is getting?
I think by and large, people feel um, pleased. I think that when situations are maybe less straightforward and there are multiple players that become involved, if well, this is what we think the diagnosis is, but now we need to check into this, or we're going to get this from here or there, then it's like, who's in charge, and then that sense of like, okay, I can trust, which is a huge issue, can get a little bit murky. So I try to help people figure out who's the person you want to go to establish who's going to be in charge. I think that, yeah, and I think at transition points when if something changes within somebody's care plan or the progress, that those become vulnerable points. People are like, well, who now? Or who am I? Who should I look towards now? And I think that there's also a grief that goes along with when treatment ends. Maybe just because treatment's ended because it's been successful, or treatment ends because a patient has died, that there is a sense of loss, being no longer connected to their medical team that they've been a part of for maybe years.
Mm-hmm. Yes. And that even though there's ups and downs and twists and turns, there's a relationship that develops. And in the best of situation, it's a relationship that provides comfort and healing, even in the face of an incurable disease. And then, yes, once the patient dies, it's not a normal expectation that the surviving spouse will come once a week or once a month to get support from the doctor that was caring for the deceased spouse.
Right.
And so that
So
that
sometimes
sense,
I end up I'm
Mhm.
seeing that I do probably maybe a third of my work or a quarter is, grief.
Mhm.
Just, simply grief related counseling. And sometimes I've wondered, is it hard for people to come back up to the office suite where they saw, you or other people? And sometimes it's like, well, it's a little uncomfortable, but I think because the environment is so soothing, it, maybe if they've run the gauntlet of some of the other stuff downstairs, but by the time they come upstairs, like, okay, I'm in this safe place.
Right. So those who don't know this,
Mm,
the physical space we have now is a beautiful space, and that the space that we're in is not where they get
yeah,
chemotherapy, it's not where
yeah,
they get radiation therapy,
yeah.
it's not where they have surgery. So it's space that maybe doesn't trigger some of those fears as much as other
Yeah,
medical spaces.
yeah. They routinely will say, "This is like a spa." Like, it's really quiet up here, and most days it really is, and it's
hmm
like, there's beautiful, views out the windows, and it's very calming for all of
What
us.
are some of the other issues that the care partner might have that we haven't touched on yet?
Mm. Oh, I'm trying to think.
I mean, they could also be going through some physical
Oh, yeah.
issues of their own, unrelated, that certainly could be exacerbated. I mean, I just was with a married couple today, and the spouse, the caregiver, is experiencing low back pain, and then there's the expectation of the physical care that they're going to be providing, and they're having their own physical issues.
Right. And caregiving can be just so physically exhausting and taxing. And sometimes people don't get good sleep. They don't maybe eat routinely. Well, they're missing doctor appointments, dental appointments, vision, even just getting a haircut is, to get out for that. So I think it's how are we looking after the health and the well-being of caregivers? Because I do see some caregivers who have some significant medical issues of their own. And in some cases, there are situations where there are more than one individual needing care in a home and plus the caregiver. So I think of one situation where there's at least three people in the household. And so it could be, they could be like, this person needs this now this person needs, and I have my own issues.
Mhm.
Yeah.
Yeah. Well, tell you what, let's open it up to some questions. We've got a live studio audience here,
Mhm.
actually a quite large group. And then we
That's why I've
also
been.
have those of you that are watching us live streaming. So if you're watching us live streaming, you can put your questions in the comment section. And we'll go first to the questions here in our audience.
A viewer, Tracy, wants to know if there's any literature that you recommend for caregivers.
There are a number of resources that I recommend. I can't list them all off the top of my head, but I would say one of my new favorites, which is hot off the press in September, is a book called Hope for the Best, Plan for the Rest. And it's like 7 sort of topic areas around caregiving. It's written from the perspective, or it comes from a palliative care perspective, but I find it to be spot on for just anything from the very beginning. And it's very clear, very well written. So
Hope for the best,
plan for the rest. And the authors, one of the lead authors is a Dr. Samantha Winemaker.
Okay, and I had a quick question. I had kind of a flashback while you were talking about the financial issues in particular. I mean, when I was first married, I was surprised and shocked maybe to learn that the number one statistical reason for divorce is finances. People get divorced over money, which I'm always surprised by. Well, the medical profession the financial issues, the wading through the insurance, and how big of an issue is this in what you're doing in the world of healthcare finance?
Well, for me, I don't have to sort of dig in too deeply with our clients around that. I've done that in the past, though, let me tell you, both personally and professionally, sorting through piles of EOBs that just keep coming, that's stressful in and of itself. And trying to understand what your benefits are is challenging. And some people will find, oh, I thought that my Medicare was going to cover this and it doesn't, or it won't even, depending on if it's an Advantage program versus a different kind, then it's like, can I even get this test done? Somebody out there is deciding, Dr. Deming wants me to have this test, but now I can't have this test, which only exacerbates people's distress. What we know is that family caregivers on a national basis provide billions, we're talking with a B, of unpaid care per year in this country. There are, millions and millions of caregivers providing billions and billions of dollars in unpaid care.
Yeah. And I would say, for those who don't know, that medical debt is the number one cause of bankruptcy in the United States. And then I would say just that in our cancer center, Kathy's role, we do have a social worker, financial counselor whose role is to do that. So we rely on Kathy. We want her to spend her time not helping patients and family members figure out the bills. We have somebody to do that, but that Kathy's role is more the psychosocial counseling for the family members. But it's a big issue, and so we do have a separate social worker, financial counselor who deals with that aspect of the questions that patients and family members may have. But it's huge. Even with great insurance, what many people don't know is even if you've got really good insurance, you may have $10,000 of out-of-pocket expense per year, even with really good insurance. And that unless you've faced catastrophic illness or cancer, you may think, oh, I got great insurance, but you may not have planned that great insurance still means you pay $10,000 out of pocket of the bill, not to mention the loss of income that your family may have and the out-of-pocket non-medical expenses, such as travel and childcare and gas and hotels, etc.
Yeah.
So, great question. Other questions in the room here?
So, Kathy, how do you de-stress after listening to everyone all day long?
It's a good question because I don't deny that hearing people's stories, they don't just go in and out. I hold those, but I try to get exercise. I try to spend time in nature. Even when I'm thinking like I should get out and go for a walk, and I should get, no, but I'm on the couch. My husband's like, let's go, and then I go and I feel much better. And sometimes it is. I would have to say. I will take like media diets in terms of not ingesting a lot of external news and other things that are distressing. I try to, put things in that are nurturing to me. And sometimes it's just Netflix or something that's.
Yeah, I would also say that the joy and professional reward that we get from being able to serve other people is a huge benefit, and that helping others solve the problem is not the same as experiencing their problems, and that you get joy from helping them, but you don't have to take those problems of every patient home with you. It is not a lack of compassion to leave that in the room because you're going to go into the next room, and you can't effectively help that person if you still are carrying all of this person's problems. So you don't have to carry their problems.
Mhm.
You help them when you're with them, but it doesn't require that you spend the next 24 hours with that person's problems. In fact, you're being you're a disservice to your job. You have to be with the next person. So, but we all get closer to some patients than others. We definitely feel their burden, and we definitely grieve when we lose them, but
Mhm.
it's with appropriate boundaries. It's because we're humans, but that the sense of joy we get from being able to help people offsets the burden that we feel when we're not in the room with them.
I would echo that. That every time I leave work, the feeling I have is one of joy.
Tim.
Good answer, Kathy.
It's really true.
Yes, I mean, tonight we talked a lot about caregiving as the cancer is being treated with radiation or surgery or the drugs involved, chemotherapy. Then there's a situation where there's always the side effects. So when someone is done with their treatments and they're on their road to recovery and maybe in remission, the responsibility of caregivers after that, post surgery and then during remission, possible side effects. Do you have people coming into your office and say, my wife had cancer 2 years ago, but I'm still working with the side effects? Could be financial, could be, what your wife is still going through, like lymphedema or something like that. Do you deal with those people in your practice?
I do. That's come up recently in 2 cases that I can think of. And in one case, the gentleman was just, his wife was in remission, but he's saying like, she's just not, I want to see her kind of get going again. And there doesn't seem to be any reason why she's not, except what he also described as her pre-illness personality, where she would sort of, maybe not be as assertive about things. And here was somebody who was really looking forward to kind of getting their life back. Like, all right, we're through with treatment. And I've sort of been looking as a caregiver, looking forward to this time when we could go travel again or do this or that. And it hasn't happened. And I'm starting to feel fussy about that or unsure. And I think there are situations too that I've encountered where somebody has become so invested and the role of caregiver has given them such meaning that as the person improves and gets better, they don't want to give it up. And that person's like wanting to be in charge of their life again. And they'll manage their own meds. They'll do this. I don't need to be hovered over. And so, but it's like, yeah, but this is my job. And, I was getting good at it. I liked it. But it's like it's a transition point, and it's where things can get a little murky at times, but helping people figure out how to release that and processing. I do a lot of processing about, post acute caregiving, like what has this been like? How has it changed you? And your experience of it.
And Kathy, as you're describing that, I'm reminded that you've had many different roles as counselors and probably have worked with couples and marriage counseling, and that, some of the things that you see, the dynamics end up being not so much about the cancer as just the dynamics that you could name another stressor,
right,
that could cause the same sort of interpersonal dynamics in a relationship.
Yeah.
Other questions?
Another viewer, Kirsten, says she loves the care partner term. It's truly a partnership between giver and receiver. Maybe reemphasize the partnership.
Yeah, I like the term too, and it's kind of filtering out there in the ethers now, with more and more people who are in this world kind of using that terminology, because it acknowledges and recognizes that if it's, you're a partner, you can be a mother-daughter in a partnership. You can be, but that we are doing this together, and we are in this parallel track. We are both experiencing it, doing different parts, but we each have our part to play, and those parts are dependent. They are separate but yet dependent, and it honors
Mhm.
the care partner.
I like that as well. I also think of the sort of the hierarchy of sympathy versus empathy versus compassion, and I kind of think of this as a little bit of a hierarchy. Some people use the word caretaker, which I'm not fond of.
Yeah.
I mean, it reminds you of taking care of a cabin or the dog, but also brings to mind the word undertaker. So there's
Yeah.
this caretaker
Caretaker.
versus caregiver versus care partner. But in both of those scenarios, there's sort of this hierarchy of what's the role. And care partner, I mean, no matter who's the one with the cancer and who's it, you do take care of each other, and hopefully the care partner realizes that, boy, wouldn't it be great if my spouse who has cancer could do something for me? How would that boost how they feel? Because as we've already described, we get great joy from helping others, and in a great partnership, you realize that's reciprocal. You can't always be the same person, can't be the giver, and the same person can't be the taker. That for the relationship to work, you each have to get the joy out of being the one who is assisting the other.
Exactly. And I think as long as we continue to frame it as a partnership versus a giver thing, then there's less imbalance.
Mm-hmm.
And it's a power imbalance. And sometimes people who have been, maybe spousal, or in some type of relationship, now it's like, now I'm the nurse and you're the this. And it's like, and it's becomes one more loss in the relationship. So yeah. And it is that piece of like, what can you give me back? And, we see situations maybe where the person who's with an illness can't get out and shop for their wife's, Christmas present or something, but they manage to they enlist other people to do some of those things. They come up with the ideas, they get somebody else, or they get online and Jeff Bezos delivers it. But it was their intention that it came from. And it's those things where the person is saying, oh, I'm still remembered, I'm still thought of, I'm still valued.
Mm-hmm. I think we're going to end it with that, and we just have retitled the name of our session. So this was no longer Care for the Caregiver; it's Care for the Care Partner. So I like that. Kathy Koenig, Master of Social Work, certified caregiver and coach and care partner to so many of our patients and their families. So thank you for being here.
Oh, thank you so much.
And thank you all for attending tonight and for watching live streaming. If any of you know of someone that would benefit by watching this program, it will be available on demand tomorrow at the Above and Beyond Cancer YouTube channel and also at the Mercy One Cancer Center website. I hope you'll join us again next week. Thanks, everyone.